Patwardhan will be joining soon. That's a roti.
Hello, thank you, Ashok, and once again, welcome everyone to this probably the last session before YROC, where we choose the final 5 rising stars to choose the ultimate winner. So, as usual, the format all of you know. Today, the judges are as yesterday. Dr. Anil Karkhani, is a well-known teacher, orthopedic surgeon. He has been mentor to many of us. He'll be there as the judge. Then Dr. Sandeep Patwardhan, the famous pediatric orthopedic surgeon, who will again be the judge. And Dr. Ganjawala is there today, Ashok?
No,
Dr.
sir.
Ganjawala is there?
No, he's not there today, sir.
Okay. Okay. So the format will be same, and
Okay, I think we have lost connection to Dhar, sir. Again, so we'd like to welcome the candidates, Dr. Shahrukh Khan, Dr. Anushrav Rai, Dr. Priyambada Kumar, Aashiket Sable, and Dr. Ashraf Shaikh. So without losing time, we can start with the first candidate, Dr. Shahrukh Khan. Please share your screen and we can start the presentation.
Yes, sir. Thank you, sir.
Go ahead. Welcome, Patwardhan, sir.
Is my
Okay,
screen
make it
visible,
full
sir?
screen. Yeah, we can see. Screen is visible. You're audible. You can go ahead. I'll time your presentation to 8 minutes. Go ahead.
Thank you, sir. Good evening, everybody. I am Dr. Shahrukh, Senior Resident from Sports Injury Center, Safdarjung. I'm going to present high tibial osteotomy, pros, cons, and its role in current scenario. So I would like to touch upon knee osteoarthritis first, which involves reduced joint space and osteophyte formation. And the medial compartment is the common compartment which is involved. It is classified by Albeck and Kellgren and Lawrence classification. Coming to biomechanics of a normal knee, the mechanical axis starts from the center of the hip to the center of the ankle, and it passes from the center of the knee joint. The anatomical axis lies around 5 to 7 degrees of valgus to it, and the normal MPTA and LDFA angles are around 87 plus minus 3 degrees. In a normal knee, there is around 55 to 70% load on the medial compartment. Just a second, sir. In a varus knee, the mechanical axis passes more medially with a mechanical axis deviation of more than 15 mm. And the causes of varus knee can be osseous deformity, ligamentous laxity, and cartilage damage. Every 1 degree of varus in knee increases the load on the medial compartment by 5%, and more than 2 degree of varus accelerates the osteoarthritis in the knee. Using the mechanical axis deviation, we can diagnose the varus radiologically, and the deformity origin can be found out by the measuring the angles. In a varus knee, the knee adduction movement is increased, which further leads to further varus and progression of osteoarthritis of medial compartment. We have 3 surgical options available for this condition: TKR, unicondylar arthroplasty, and osteotomy. But in total knee replacement, there is activity limitation, while the knee joint is preserved in both the unicondylar and osteotomy, and the mechanical axis is corrected in both of these. Most of the young patients are dissatisfied with the results of TKR. That is why we have resolved to unicondylar and HTO again. These are the overlapping indications of unicondylar and high tibial osteotomy. Now, coming to high tibial osteotomy, it was introduced in 1961, popularized in 1965. The goal was to reduce knee pain by shifting the load to the lateral side and decreasing the progression of medial osteoarthritis. Its use declined due to improvement in arthroplasty, but it is re-emerging now. I will be talking about the high tibial osteotomy in these points: indications, planning, surgical method, technical consideration, and results. The indications are relatively younger patients who have good range of motion and isolated medial compartment osteoarthritis with no severe articular destruction. And the contraindications are more than 15 degree of flexion deformity with less than 90 degree of flexion. More than 20 degree correction is required, and inflammatory arthritis. We have two options of open wedge and a closed wedge osteotomy. In the open wedge osteotomy has a higher accuracy of correction because the gap can be controlled. It has a better survival at 10 years, less soft tissue dissection, and the proximal tibiofibular joint is more preserved. The posterior slope is increased in an open HTO, and it is decreased in the closed wedge high tibial osteotomy. The limb length is increased in open wedge, and there is decrease in patellar height in the open wedge, which can cause knee pain. Coming to pre-operative planning, we require full-length X-rays with the patellar in center, and these should be weight-bearing X-rays. And the osteotomy can be planned by a Miniachi method or Dugdale method. I will be discussing the Miniachi method. First, we draw a mechanical axis, which is M1, and calculate the mechanical axis deviation. Then we make a Fujisawa point, which is 62.5% from the medial tibial plateau. And the hinge is placed at the tip of the fibula or the fibular joint. Another mechanical axis, which is the future proposed mechanical axis, is drawn through the Fujisawa point, and a line is drawn which connects the hinge to the new mechanical axis. Another line is drawn which connects the hinge to the center of the ankle, and the angle between these two lines is the correction angle. Next, we have to take a point which is at least 30 millimeters below the medial tibial plateau and join this point to the hinge point. This is the proposed osteotomy site, and the angle is superimposed for correction. This is the correction angle which has been superimposed. The width of the wedge which is required for bone grafting is calculated. The osteotomy is performed through this gray line, and the wedge is opened and the limb is aligned to the new mechanical axis. Bone graft is placed and appropriate plate or screws can be applied to stabilize this. Coming to surgical method, a medial incision is given, and the patellar tendon and the posterior structures are protected by retractors. A guide wire is passed through the proposed osteotomy line. These are the zones in which there is, if we place the osteotomy along this line in the WL zone, there is less chance of cortical fractures on the lateral side. The osteotomy is performed in anterior, middle, and posterior cortex using a saw, oscillating saw, or osteotomes, and the osteotomy gap is opened with a lamina spreader. Appropriate implants can be applied. We have options of Tomofix plates, which provide more stability. Pudu plates and fixators are also an option. A biplanar osteotomy is preferred over a monoplanar because there is lesser patellar height lowering and lesser posterior slope angle changes. The posterior slope angle changes with osteotomy. In a closed wedge osteotomy, there is overextension and the slope is decreased, and there is increased load on the PCL. While in open wedge osteotomy, there is increased slope and load on the ACL is increased. A double osteotomy is preferred in severe varus deformities, but it cannot replace TKR because the lateral side laxity due to higher joint line congruence angle will lead to a failure. The Fujisawa point has also been modified by Jacob et al. Depending upon the cartilage loss, we can shift from the midline and place the new mark to align the axis and perform the deformity correction. The future of planning is 3D planning. and appropriate size wedges can be made, which can be placed inside the osteotomy gap while the plate is being or implant is being applied. The results of HTO have been significant improvement in pain and function. The closed wedge and open wedge HTO have equal complication rates. Unicondylar and HTO have similar pain and function outcomes. There are more adverse events in the HTO as compared to unicondylar, and 10-year survival rates are around 80 to 90%. These graphs show the comparison between unicondylar and HTO. The post-operative pain and post-operative complications were higher in HTO. The knee function outcome were better in unicondylar. Range of motion was better in unicondylar as compared to H2, and the revision rates were also higher in the unicondylar arthroplasty. The complications of HTO are different. The common complications are pain, stiffness, implant failure, fracture, infection, non-union, and deep venous thrombosis. And the paralysis of the fibular CPN palsy is more in the lateral closure, closed wedge osteotomy. The conclusion is that indication is in young and active patients, which are usually less than 65 years. Pre-op planning is required, and we can buy time for performing a TKR by doing a HTO first, and it is associated with a lot of complications also. Thank you.
Okay, thank you, Dr. Shahrukh. You took 1.5 minutes more than your allotted time. So we move to judges. Over to Karkani sir for questions.
Good presentation, Dr. Shahrukh. Can you hear me?
Yes, sir. Thank you, sir.
Yeah. So the complications you are going on the medial side, what happens to the medial collateral ligament which is attached there? And what happens to the insertion of the sartorius, gracilis, and semitendinosus?
Sir, while performing the open wedge, we have to divide the superficial MCL first to open the wedge, actually, and the MCL is, sir, superficial MCL is divided during the procedure, sir.
So superficial MCL is not divided even in a TKR to my mind. So here you are dividing the superficial MCL.
Yes, sir.
Then what happens to the MCL? Because the plate is coming over that. So what happens? You are divided and you put the plate over that. How is it going to unite? What is going to happen? It will remain wide open. Have you thought about that? What does the literature say on that? What does the literature say on sartorius, gracilis, semitendinosus, which are also there, which are internal rotators, which are important for knee locking?
Sir, I have not read about that, sir.
That is a major thing that nobody can answer. What happens to the medial collateral superficial ligament there? Because you are going to right through that. Is it not?
Yes, sir.
Yeah, compared to that, if you want to compare HTO, then the closed wedge is more easy. The Coventry one, where you put a patient plaster for 6 weeks and then that's it. The complications rate will be less there. Have you
Yes,
had any comparison of the two? Is there any randomized control trial of the two? Your literature review?
Sir, there was a literature review and a trial between both open and closed wedge, but the tibiofibular joint is, sir, involved in the lateral closing wedge osteotomy, and the nerve complications are higher. So, and the thing is that we cannot control the osteotomy correction properly in the closing wedge as compared to the open wedge. So it is open wedge is preferred more, sir.
The common peroneal nerve doesn't come over there at all because we are going on the lateral side to that by superficial dissection of the anterior compartment of the leg muscles. That doesn't come there at all. Earlier, I remember Dr. Satish Modi used to identify the nerve, he used to osteotomize the head of fibula and then tighten the fibula because it used to be lax after correction. But subsequently, that was given up and in plaster it used to correct. So that is not true. Common peroneal nerve doesn't come over there. It is on the lateral side. It's going to the peroneus longus. Where are we going to come over there? Yes. So these are the questions that you have to think about. What about the MCL and what about the sartorius, gracilis, and semitendinosus? Okay.
Okay, sir.
Sandeep?
Radwan sir,
Yes,
any
sir.
question?
Yeah,
हाँ बोल ना.
I'm just on the road. There may be some disturbance,
हाँ.
but just a question to him: has he ever seen a lateral closing wedge osteotomy?
No, sir, I have not seen, sir.
So then you don't have an idea because you haven't read the literature either. That is one. Second is, have you compared the literature of fixator assisted correction versus medial open wedge osteotomy, and whether that offers more benefit with gradual correction as compared to an acute open wedge osteotomy?
Sir, there was an article by Dr. Mangal Parihar, sir. Sir, I have not gone into detail about that, but there were chances of infection were more due to
लाइट कलर कोड तर बसला वगैरे तर तरी सुद्धा त्रास होतो बेड केलं नाही सर.
Okay, I think so. Shahrukh, you have to study a lot on this closed wedge, open wedge. Yeah.
Yes, sir.
We don't have to run after that implant which they want to sell over here. You see, because we have done hundreds of closed wedge osteotomies when it came to Coventry.
Yeah, I think the focus was not literature review; it was presentation of his implant.
You have to have literature review, and you are quite junior to know about all this. You have to have literature review. This is what the literature review symposium is about. Presentations. Not your personal experience because you are junior in that, is it not?
Yes, sir.
Right.
Okay.
Okay, thank you, judges and Dr. Shahrukh. And we move on to our next candidate, Dr. Anushrav Rai. Please share your presentation and we can start. Okay, play. We can see the presentation.
Sir, am I audible?
Yeah, you're audible, visible, and presentation visible. You can start.
So I'm presenting a literature review for the principles and reasons of failure for cemented femoral stems. So why the methodology first? The PubMed and other relevant sources were used to search for publications regarding this literature review. National Joint Registry of different countries was accessed from their respective websites. Articles not relevant to the discussion were filtered over the not Boolean operator. Tavli's artificial intelligence algorithm was asked the question cemented stem versus uncemented stem, and French paradox, cement thickness in femoral stems. So why cemented stems? The 20th National Joint Registry data of the United Kingdom shows a decrease in trend of cemented hips. Indian scenario, in spite of having a higher population, reports lesser number of hip arthroplasties as compared to UK, and their registries can be studied for valuable insights. Hybrid fixation, which uses a cemented stem and a cementless acetabular cup, has seen the highest rise in popularity in the recent years in the United Kingdom. Uncemented and hybrid hips roughly account for all 76% of the hips done in United Kingdom. So cemented acetabular cups are continuously falling out of favor in the Western countries. Although cemented acetabular component was considered gold standard with no higher revision rates than uncemented and hybrid fixation, there is documented slightly worse outcome on quality of life and functionality outcomes in the study by Frank Van Praet et al. In
See, can I interrupt you, Anushrav?
Yes,
So
sir.
you are reading the whole slide. What is happening is you have got 3 and 3, 6 and 9, 10, some 18, 19 sentences. This is not correct. When you have a slide presentation, you should have not more than 5 to 6 or 7 lines on the slide. So you are reading it so fast because you want to finish it off in 8 minutes. That's not correct.
Yes, sir.
Whenever you have a presentation, you have to have not more than 7 lines. So you have to concise that into 7 lines. Now that was the point in reading so fast. I can't understand what you are reading also.
Okay, so
So you have this slide, you have a concise what this slide is going to explain. That's about it.
So this slide shows the current literature opinion that the cemented acetabular components are falling out of favor. The pie chart in this slide shows that out of the total 14,47,000 hips in the UK National Registry, 3% were revised, and of the 3% revision surgeries, hybrid and the uncemented femoral hybrid and uncemented THRs had the lowest revision rates. That's what I wanted to convey with this slide.
So hybrid meaning what? Cemented stem and non-cemented acetabulum?
Yes, sir.
Huh?
Yes, sir. Yes, sir.
Those were 97%.
No, sir. The 97% and the 3% is the total amount of total hip arthroplasties in all the 22 years of the
Okay.
all the 20 years. Out of
And
all
now,
this out of all the revisions, the revision rates were calculated, and it had the least amount of revision rates.
in what?
Of all the 43,682 revision hips, primary
Yeah,
revision.
but the revision rate was less in what? In which ones?
Sir, in hybrid cemented stems.
That means hybrid cemented stem and uncemented acetabulum. Is that
Yes.
what you mean to say?
Yes,
Huh?
yes, sir.
Or you are confused on that?
No, sir. It's visible on the graph on the left-hand side.
So what does the graph say?
So the cemented stem has the least revision rates, primary revision rates.
Okay, go ahead.
So furthermore data suggesting that cemented stems are better than the uncemented stems, especially in the 2020 level 3 study of Australian Orthopaedic National Joint Replacement Registry. The cemented femoral stems over the 15 years of time had 1% cumulative incidence of complication rates as compared to the uncemented stems, which had higher revision rates, especially after 7 to 8 years primary procedure. So photo is the crux of the whole presentation. It shows type 1, type 2, type 3, type 4 type of cemented stems which are manufactured globally around the world. So type 3 and type 4 are the most rare one. I mean, they are available, but they are not as frequent as the type 1 and type 2, which are force closed. Type 1 is the force closed design, and the type 2 is the shape closed design. So I'm going to limit our discussion with the type 1 and type 2. So regarding the French paradox, because no discussion about cementing remains complete without discussing about French paradox. So there has been a very last 14 years, there has been a concurrent discussion that if you use a thinner cement mantle, let's say of 1 mm with certain design, CMK3 design, so that gives a better long-term results than 2 to 4 mm of cement mantle thickness. But a recent November 2023 study published in Germany, it favors the thicker cement mantle of 2 to 4 mm, which is good for after analysis of German, Danish, Swedish, Norwegian, Swiss, New Zealand, English, and Australian endoprosthetic resistors. But still, the debate is out, and it French paradox supporters have their own doubts about it. There are three different modulus of elasticity for the whole cemented component. Bone has 12 to 18 gigapascals of modulus of elasticity. Cement is the weakest one, and stainless steel is the implant. So in this slide, the picture shows the main division between the type 1 and type 2 implant. So in the type 1 implant, in the type 2 implant, where there is good fixation between the stem and the cement, the debonding occurs at the bone and the cement interface as mentioned in the left-hand side diagram. But in the type 1, force closed, the micro movements occur at the stem cement viscoelastic interface and the bone cement interface is protected, hence leading to the longevity of the implant. So cement is and always will be the weakest link in terms of modulus of elasticity, hence the implant design matters a lot. So the type 1, force closed or polished taper design. This fixation is obtained by controlled subsidence in the mantle. And there is a flexible distal centralizer that collapses as the stem subsides and prevents point loading of the cement by stem tip. So all in all, the point of this design is you don't get a stable fixation on the table itself. You put a polished taper design, and up to 6 months into 1 year, this polished taper design subsides by 1 to 2 mm. And it gets its full stability by the end of 6 months. It has a survival rate of 98.7%, 20-year survival rate reported in the NJR. Type 2 is the shape close or the composite beam. It is different from type 2, type 1 stem that it has grooves or it has a calcar, a collar, which prevents subsidence and it loads the medial proximal aspect of femur. The original Chanley prosthesis was a composite beam design with a very small collar if looked closely. The original Chanley stem had a long-term survival rate of 78% at 35 years, and these current designs have a 8-year survival rate of 97.5%. So what is better? Ideally speaking, both give almost similar 20-year failure rates, slightly better in the type 1, but the type 1 has significantly lower 8-year revision rate a 2019 study comparing on 292,987 hips. And the shape close design had 1.7%, and it is consistent with the previous studies. The failure modes seem to differ, with polished tapered stems failing more often because of the fracture and composite beam stems failing more because of aseptic loosening. Now, this discussion remains incomplete with the bone cement implantation syndrome. Rasir et al. In 2019 showed that of 0.44% of the total patients didn't survive in his study regarding bone cement implantation syndrome out of 915 patients who had cemented arthroplasty. But the usual cause of fatal BCIS were existing organ failures, patient on vasopressors, and other comorbidities. So the long-term result is for BCIS is this: the cemented femoral fixation should be used cautiously in patients with severe systemic disease, including cardiopulmonary disease and cancer and lung metastasis. The use of cemented stem has definitely declined in favor of cementless options. Registry data and clinical studies suggest the same, but for patients greater than 75 years of age and DOR type C of medullary canal, they should be preferred with cemented femoral fixations. These are my references. Thank you.
So thank you, Dr. Anushrav. I think you took just 30 seconds more than the allotted time, but that's fine. Karkani sir, you have any questions?
Yeah, first of all, thank you, Anushrav, for not reading the slide. That is a very positive thing that you did today. Yeah, so congratulations on that. So there's not much of a difference between the one which has a collar and which is a polished taper, is it?
Sir, the design is the difference. I didn't know the difference between both these designs before presenting this topic. So I read about it, and then I came to about the difference in the collar. So the design is different, and there is one more difference regarding the mode of fixation. Like if we do the taper slip, which is the most commonly used, which I have seen in India, the taper slip depends on the fixation. The fixation finally happens at 6 months, they say, and they have a centralizer, a plastic centralizer, which allows it to slip down. But the second one, the composite beam one, it is a solid fixation, and it is obtained on the OT table itself. So that's what I read about it, that I haven't seen it. So if you put a thick cement mantle and it's a complete whiteout, when you analyze the post-operative X-ray of the type 2 stem, there's a complete whiteout on AP and lateral views that shows that the cementing is good enough. But in the type 1, there is a little amount of, let's say, air pocket where the centralizer is in the immediate post-op of the type 1. In the immediate post-op of the type 1 stem. So, which allows it to sink down over the course of 6 months to 1 year, the better passage of forces. And as I showed in the photo, that the debonding occurs because if there is a good debonding or the loosening of the cement occurs, if there is good fixation between the implant and the cement. In type 1, there is good fixation between the bone and the cement, not the implant and the cement. That's why type 1 has lower rates of loosening.
Because it will subside because it doesn't have a collar. So in due course of time, it will go down, it will settle in the cement mantle, no?
Yes.
That's what you want to say. But have you compared with the American people? They keep on doing uncemented right and left.
I mentioned it was in one of my slides. In 2020, they had 94% of uncemented total hip arthroplasties. So that's why there was this very stark concern in between the UK registry data and the US registry data, that US registry had 94% uncemented total hip arthroplasties, and they depend more on the biological fixation. But the UK data prefers more on, it's steadily rising up. The graph is steadily rising up for hybrid fixations. So
again, you mean it is going for uncemented stem in UK?
No, sir. In UK, they are going for cemented femoral stems and uncemented. So total both is 76%. The hybrid is around 40% and 36% for uncemented femoral stem.
So why are they going for the cemented again when the USA data is 97% and non-cemented?
Yes, in US is 94% is uncemented.
So why there's a difference?
Because of the lower failure rates, and I didn't read about it, but maybe because of the I mean, I'm guessing about it that they have a subsidized healthcare. UK has a subsidized healthcare. So if the cost of for implant is less, that becomes their implant of choice. I have seen in some options. Plus, cemented total knee replacements have a very good track record worldwide. So
So what
maybe,
is the Indian scene now? Literature is there on India,
sir,
or there is no bone registry only?
sir, there are registries, but the data is not so easily accessible, and we usually tend to follow the Western trends, specifically US, UK, and Australia trends. So in India, but sir, in uncemented is the primary preferred before 75 years of age. After 75 years of age, especially after 80, people prefer cemented stems, but then also I have seen very few. I
But
mean,
in uncemented is preferred even if that implant is loose on the table.
no,
I
sir.
mean the broach.
No, sir. No, sir.
Then, and what is the degree of osteoporosis in India? We don't eat mutton, chicken, and we don't have any milk. And there's what is the
Yes.
status of the Dhar index? You said about the Dhar index, no? How much it is? If it is 0.5, it's good. If it keeps on going to 0.5, 0.8, and 1, then it's no use. Then you have to use cemented. And right and left, they use it non-cemented strips, rattling, and then the entire thing loosens. Then there is a fracture, and then you have that classification, is it not?
Yes, sir. Yes, sir.
Then, so if it is loose on the table, it's out of question to put that. And besides that, we have the Singh index. Singh index is a very good thing for osteoporosis. We can do the DOR index and we can do the DEXA also. If all these are corroborating, then we should decide on table what to do and what not to do. Is that given anywhere? That way, what I'm asking you?
It has been mentioned in some papers, but that is the usual algorithm which everyone follows, sir. Yes, sir. But I didn't come across a specific paper in this specific algorithm. So
That is basic because if it is osteoporotic, it will be loose on table only. You can't put it. You have to have cement ready. Is it not?
Yes, sir. It is. We usually keep cement ready for every total hip case, but the implant companies have a lot of hydroxyapatite coated and special coated uncemented implants also available. So, if because of their extra thickness, uncemented, and they have the lesser complications in using it because you have to use you have to first use a restrictor, then you have to put in the cement, and then you have to put a lavage, and then you have to. So usually it becomes cumbersome, and that's why.
That's not the cumbersome. If it is loose, the broach is loose, you can't put it, my dear. How can you? It will rotate. Once it starts rotating, there will be no interaction of the bone growing into whatever you have, whether it is with whatever hydroxyapatite you put, how it will grow. Basics of fracture union, no?
Yes, sir.
Is it not?
Yes, sir. Yes, sir.
Then,
is there.
Sandeep.
Yeah, so nice analysis, and you have read quite well, and I think your analysis is insightful. Just one question is that do you think there exists a large amount of bias in the publications across the continent versus the American publications? How much is the bias in all these papers that you found? Because the NHS, as you rightly said, changing policy requires a lot of legislation, and it comes from the bureaucracy, whether to switch from a particular implant to another implant. It is not easy to just, in India, it's an open market. Anybody can do what they want.
Yes.
Whereas it depends on
Unfortunate.
where your surgeon is trained. If he has been to America, he'll do uncemented. If he's been to UK, he'll do cemented. Whereas in UK, it is difficult to make policy changes as far as implant because of costs and bureaucracy. So how much is the bias to push towards uncemented implants in the American literature, and how much is the bias to not change in the UK literature? Did you find evidence of bias in the literature?
In US, there is heavy favoritism for uncemented implants.
Yeah, that's obvious. What I'm asking is in UK, because you are talking on cemented stems.
In UK, there is clear trend for cemented femoral stems.
Yeah, we know that because it was the origin of the cemented stem, no? Chanley and Wrightington Institute, and they still boast of first generation, second generation techniques of cementing, which is why they are talking of long survivorship. They have the data, and they are not very. The British basic attitude is not to change very easily. They are quite sticky in their approach. So, question is there a negative bias in the UK not to change, as there is a positive bias in US to you do everything uncemented?
Sir, the bias is for cemented. The bias is for cemented stem, not for cemented acetabular cup.
Yeah, I got that. That's what I'm
Yeah.
saying. They're doing hybrids. Your topic. I saw the title is cemented femoral stems.
Yes, sir.
We are not talking of acetabulum. I'm asking you, is there a bias not to change in the UK publications? Did you find in the literature a bias towards not changing their cementing because they invented it?
Yes, sir. I mean, if you see the recent year, the data in the National Joint Registry itself, publication-wise, sir, publication-wise, there are, if you try to find out about something, you will find publication for any topic for and against. But in UK-based papers, yes, there is not a lot of data, a lot of papers supporting for uncemented femoral stems. First thing. Second thing, the stress is upon better techniques of cementing. What the papers I
Correct.
saw.
So more and more bias is towards methods of cementing,
Yes, sir.
and more papers are only on cemented. There is no democracy where you have equal amount of uncemented papers coming out of UK.
Yes, sir.
So there is a certain bias which prevents them from doing uncemented.
But their numbers have been constant, sir. Like from 2009 to 2000.
Yeah, that's national health policy. No, you can't do much about it.
What about in Europe?
Sir, in the Europe data, also the Norwegian and the Swedish registry, they also have a mixed bag of experience, but they prefer cemented. I mean, they are not very sold for uncemented components on the both side, but they don't discourage also for the cemented. They are kind of neutral, like Switzerland. They are very neutral for everything.
And Southeast Asia, China, Japan, what is the data there?
For Southeast Asia, sir, I reviewed South Korea. There was 14,000 in their registry, and mainly it was for osteoarthritis. From what I remember, they were in favor of uncemented. Around 60 to 70% was around uncemented.
And China, Japan?
Sir, I didn't review China and Japan.
Okay, doesn't matter. Okay, good. Any more questions?
Okay, I think
I have to conclude that one should be really careful on table, that because it is easy and cementing is cumbersome, you can't put uncemented if the whole broach is rotating. The trial one, you see, then you can't, because even no matter how much you have that hydroxyapatite, if it's going to rotate, it's not going to grow. So it will be loose, and then all the complications.
okay. Okay, thank you, sir. And thank you, Anushrav. Let's move on to the next candidate, Dr. Priyambada Kumar. Please share your screen presentation and let's go ahead.
Yes, sir. Is the slide visible, sir?
Yeah, slide is visible and you're audible. Go ahead.
Good evening, respected judges, teachers, and dear colleagues. I'll be presenting on pre-operative traction versus side bending X-rays for assessing the curve flexibility in adolescent idiopathic scoliosis. Now, in AIS, planning for the surgery using pre-operative flexible radiographs is essential to classify the curve, note the shoulder symmetry, to confirm the structurality and fusion levels, and subsequently plan the approach of surgery. There are numerous ways of doing these analyses, the most common being the supine side bending X-rays and the traction X-rays. But what we need to understand is that the primary goal remains the same no matter which method we use, and that is to predict and plan the post-op coronal balance, surgically achievable with the current instrumentation techniques. So what's all the fuss about? Accuracy of prediction of the post-op achievable correction by bending X-rays has been questioned time and again by many authors, and yet it remains the gold standard at majority centers. Makes us wonder, should traction radiographs be considered the new gold standard in pre-op evaluation? Our aim today is to review the current literature around comparison of traction radiographs and supine side bending radiographs to assess curve flexibility rate and to predict the curve correction achievable post-operatively with optimal coronal balance. 6 databases were searched and articles published between 2015 to 2023 was included in my review today. The following search terms were utilized and studies were excluded if they included a non-AIS cause of scoliosis. If they were case reports or preliminary studies, they did not comment on the post-op outcome, or the surgical approach was used something other than posterior spinal fusion only, and if it was printed in non-English literature. A total of 11 articles were included in my review. Now, based on a primary study by White and Punjabi et al., a common perception was formed that traction X-rays are inferior to side bending X-rays, except in curves that are greater than 53 degrees. However, recent literature begs to differ vastly. Flexibility rate depends on the level of the apex of the curve rather than just a generalized cutoff in the curve magnitude. If the apex lies proximal to T9, the flexibility rate is much higher for traction radiographs as compared to side bending radiographs. As we move caudally, the flexibility rate is still higher for the traction X-rays, but the difference between both values start to reduce as the apex of the curve moves caudally towards T12 to L1. This is primarily explained by the fact that rib cage plays an important role in enhancing the stability of the normal thoracic spine. Coming to the first attribute, that is the correction in curve magnitude, also known as the flexibility rate, number of studies have already established the superiority of traction radiographs as compared to side bending radiographs to assess the flexibility rate and comment on the post-operative outcome. Vertical forces acting on the traction X-rays cause an overall increase in the flexibility of spine in all 3 axes and leads to derotation of the spine. And the amount of derotation in these X-rays is superior to bending X-rays when compared to the post-op X-rays, as you can see in this case example published in one of the literature studies, where the traction X-ray outcome is far similar to the post-op X-ray as compared to the side bending X-ray. The major pitfall of side bending X-ray is that it is largely dependent on the patient's muscular efforts. It has low reproducibility and has less accurate prediction of the post-op correction. In a review published in 2018, however, it was seen that bending X-rays was still the most commonly used method in spite of the established superiority of traction X-rays. The argument given by most centers was simple, that traction X-rays cannot be standardized. The next year, O'Neill tried to standardize the traction applied to the patients, and axial traction force of 1.5 times the body weight was applied to the patient in TR group and was compared to a subsequent side bending cohort. This method was safe, well tolerated by the patients and independent of the patient effort. And again, standardized traction gave a better outcome in predicting the flexibility rate to the side bending radiographs. Now, when you look at these radiographs, the first thing that comes to our mind is the correction of the curve magnitude, as seen on the pre-op X-ray and then on the side bending X-ray, and again on the traction X-ray. Even when we look at the post-operative X-ray, the first thing that we see is the amount of curve magnitude that is corrected. But when you look at the patient clinically, post-operatively, is the cosmesis truly corrected? If you notice carefully, the patient still has asymmetrical shoulders and still a persistent loin crease. This brings me to the second attribute, which is very important: shoulder balance and apical vertebral translation. Coronal plane correction does not merely mean a reduction in the Cobb angle. Cosmesis correction, the deformity correction, is inadequate and incomplete unless we comment upon the shoulder balance as well as the apical vertebral translation, both of which cannot be calculated on side bending X-rays. Correction of the shoulder level on traction X-rays is significantly similar to that on the post-op X-ray. Traction X-rays give an excellent idea of the rotatory as well as the translatory capacity of the curve. And AVT is of paramount importance in planning the surgery in terms of the surgical approach and if and when osteotomies are needed. However, shockingly, it is seen that existing literature is vastly deficient on correlation of AVT with the traction and post-op X-rays. Radiation exposure to the patients is not a joke. It has to be taken seriously. In a study published in 2016, on AIS patients who were treated surgically many years back, it was seen that a mean of 16 radiological examinations were done for these patients from the beginning of the diagnosis until 2 years of follow-up post-surgery. The overall cancer rate in these AIS cohort was 4.3%, which was a shocking 5 times higher than compared to the age-matched population. Traction X-rays can be a small part from our side to try and reduce the radiation load on these patients. Now, do we need to include both these type of X-rays for our pre-op evaluation? In a latest study published this year itself, 32 spine surgeons reviewed 30 Lenke type 1 curves and independently selected the upper and lower instrumented levels for fusion. What was reported that it is not necessary to use both these types of X-ray for flexibility assessment, and it is up to individual surgeons' protocol to decide which one to use. However, the major drawback of this study was that they had included only Lenke type 1 curves, and that selection of upper and lower instrumented levels are highly subjective. So the take-home message today would definitely be that traction X-rays fare better to side-bending X-rays because they are easy to obtain and reproduce. They are independent of the patient's effort. They reduce radiation exposure to the patient. They are more accurate for prediction of the post-op correction, and they provide additional information such as shoulder asymmetry and truncal balance. Personally, what I realized at the end of this review of literature was that existing literature primarily focuses only on curve reduction, and negligible importance is being given to parameters which predict the overall post-op outcome, which include rotation and translation of the apices, truncal balance, as well as shoulder balance. And future studies are definitely needed for better evaluation of the traction and bending X-rays for additional information about shoulder balance and translatory capacity of the curve. Thank you, sir.
Thank you very much, Priyambada.
Thank you, Haya. So thank you, Priyambada. Thank you. So how is this traction X-rays taken? Can you tell us?
So the patient is made to lie on the radiolucent X-ray table, supine, and for this, 2 people are needed. So usually the 2 fellows go, it's a supervised X-ray. 2 fellows go to the traction room with the patient. There are 2 types, sir. If we are doing a normal traction X-ray, one fellow is holding the patient from the mandible at the junction of the mandible near the angle, and the other patient is holding the ankle. And a uniform traction and counter traction is applied by both. The patient is explained regarding the whole procedure so that they don't panic during the application of traction. And then both the fellows concomitantly apply the traction and counter traction. After sustained traction for 30 seconds, we take the shoot of the X-ray. Some centers are trying to do a standardized X-ray, sir, where they put it with the apparatus, where a collar is put at the angle of the mandible and straps are put at the ankle to put a uniform weight for all patients. But that facility is not available at our center, sir. So we do it under supervision of 2 fellows.
So how do you know how much the fellows have to pull?
So that is equal traction and counter traction that we give, and basically standing on the ankle, keeping the knee straight, and then we just pull back the maximum traction and counter traction. So that is a problem, that we are not doing the standardized traction technique. That is one limitation that we do have.
So you'll have to have a standardization of fellows also. They should be strong and not.
Is there a gender discrimination here then?
Priyambada, have you given traction?
Yes, sir.
Okay. So yeah, so no other questions from my side on that. Only thing, that's what I wanted to know, how it is given, and there's no standardization. I was just thinking that if you make the patient like how they swing on the tree, no? So their own weight. So suppose you have a bar there and you make the patient hang with the like they do on the trees in the boys in the rural area, and that way you can do, and then entire body weight will have traction and counter traction will be from the hand. That way, just think about it.
We can try that, sir.
Yeah, Padwan, sir.
Yeah, Priyambada, we are in 2023, ending of 2023.
Yes.
Yeah, we have 3D CT scans available. We have modeling available. We have 3D printing available. We have OARM available. We have various tools to analyze the rotational malalignment. We have intraoperative control of derotation maneuvers. I find it hard to believe that in Bombay hospital you are putting
Sound is not there. You're muted, Sandeep. Sandeep is muted.
Yeah, I think.
being said.
Okay.
Did you compare your traction X-ray to the halo vest traction? Is it superior to doing a halo vest and giving sustained traction, then taking an X-ray? And if you believe that traction is the best way, why not put the patient in bed and give traction for about 6 weeks before you operate?
Thank you for the question, sir. So there was an issue with the audio. I could just hear the last part of your question regarding the halo vest and where you asked me about.
No, I was asking about the advanced technology available to us today, including intraoperative CTs, O-arms, 3D printed models, which tell you exactly about rotation, because your last statement that you were shocked to see that there is no way of assessing rotation. And it is surprising to see. I don't think that is true at all. You are not looking at the right literature. And if traction is the way to go, why not admit the patient and put him on 6 to 8 weeks of traction before you operate? Stretch out all the soft tissues. Why are we operating by just a traction film? Don't you think this is pretty primitive? And that is why nobody is doing it, because there are better ways of doing it.
So, sir, coming to the first part of the question, the whole purpose of traction X-rays is not just to assess the rotation. Rotation is an important part of it, yes, but the traction film, so many a times it helps us to decide the instrumented levels. Instrumented levels are mostly, first and foremost, they are decided on the erect standing X-rays, but there have been scenarios.
Priyambada, I understand all that. What I am saying is that you are using plain radiographs as a technology of imaging. Whereas I am pointing out that there are far superior methods of imaging the spine, which gives you multi-dimensional analysis, including modeling it pre-operatively so that you can decide all this. Why are you not using those, and why are you relying on a traction given by fellows, which is non-standardized?
So far, this method has served us very well in planning as well as planning the treatment correction. Scoliosis surgery, especially at the center that I work presently, it's already a very expensive surgery. The patients are apprehensive, parents are apprehensive. So something, if it can be achieved with a primitive technique, then I believe, plus the 3D CT, it will subject the patient to a higher radiation. So I think if something can be done with a simpler technique, then why unnecessarily go for?
You are working in Bombay hospital?
Yes, sir.
Priyambada, you tell me one thing. What is the literature review on this traction X-rays pre-operatively for scoliosis compared to bending?
So, sir, compared to bending, as I've pointed out, literature suggests that it gives a better result than side bending X-rays.
Review of literature you should have, no? Because abroad, what will happen is if you go to USA, UK and all, they'll have standardization, like bending standardization, the traction, then fellows and whatnot. So, have you reviewed the literature, and is there any p-value?
Yes, a p-value when compared for the flexibility rates between bending and traction X-rays, it's less than 0.001, be it standardized traction or non-standardized traction. Even side bending X-rays, sir, to be arguing on the point that traction X-rays are not standardized is not completely correct, because side bending X-rays are not standardized either. It is vastly dependent on the patient's muscular efforts, how cooperative the patient is. Plus, if it's an older patient with a very huge curve, there have been times where the patient is not cooperative for the side bending X-ray at all. And when you see the erect X-ray and the side bending X-ray, it's as if it has not made any difference at all. Whereas when you compare it with the traction X-ray, you see a vast decrease in the curve angle by straight away 18 to 20 degrees.
So does the literature support traction X-ray compared to bending?
It does, sir. It does.
Have you told us the review of literature on this on your presentation?
I have, sir. If you would allow me to share my screen again.
Okay, for 1 minute. What is the review of literature on both? Can we allow Ashok?
You can just have a look, sir.
You be concise and you tell the summary of this.
Yes, sir.
Hmm.
So, sir, this is the result when standardized traction was applied. This is the major Cobb angle when we see in the standing erect X-ray. This is the value with the bending X-ray, and this is the value with the traction X-ray. The same goes for rotation as well. So most of the studies, these three are the primary studies that I had reviewed, sir, because these are the most reputed journals that we usually refer to. So all these three journals, these authors, they have supported that traction gives a better outcome, supported by the p-value, by the statistical study as well. The only problem being that, can I stop the screen share, sir?
Yes, sure.
The only problem being that side bending x-rays are still being followed more because people are stuck with the argument that traction is not standardized. The ideal method to perform the bending x-ray is when the rib cage is touching the pelvis, but that cannot be decided as standardization, I believe, sir, because again it is very much dependent on how cooperative our patient is, the muscular effort and all of that.
Okay. Yeah, okay, good.
And so coming to the second question that Sandeep sir asked, so our patients won't be willing to lie in the ward for 6 weeks with traction, sir. And halo traction, we can send them home with the halo traction. But again, these patients are already apprehensive. Most of these patients plan their surgeries. The scoliosis correction comes as a planned surgery to us. So most of them, they plan their surgery, their school leaves accordingly, everything. So time is very much limited. So in such a scenario, this like I said, this technique has worked well for us so far. So I don't think those kids need to be subjected to an additional burden. They are already carrying the burden of the deformity and the apprehension of the surgery. So
holding the mandible and giving traction is not a suffocating thing for the patient or what?
yes, sir, but we explain it
No,
to them.
I think, Priyambada, you have to make a very clear distinction in science and what is practical. And if you are talking about sensibilities of the patient, pulling him to take an X-ray is hardly being sensitive with all that burden that he's carrying, psychological, financial.
Priyambada, you put a rod and let him hang like that on a tree. Try that. Tell Arvind. Arvind was my husband.
I'll try that, sir. I'll tell him.
Tell. I have told him that. You are working with Arvind, no?
If it's a planned surgery, plan it well. Give traction. Halo West is still a valid method of doing it. And after that, you put your minimal invasive fixation.
Yes, sir.
Okay, as a joke, what happened is when I was a registrar, I had a weak husband. So when I used to give traction, the mama has to hold that weak husband to give counter traction. So husband and mama on one side and myself on the other side. आणि खरंच आहे राव देशमुख होतं. He was yeah, he's gone to UK, God knows where he is.
Yeah.
He was actually from G-Surg and he was doing allied in ortho. Yeah.
Okay. Hello, thank you.
Okay, Priyambada, thank you. Next.
Thank you, Priyambada. Thank you, judges. Let's move on to the next presenter, Dr. Aashiket Sable. Aashiket, you can share your presentation.
Good evening, sir. How are you?
Yeah, good evening.
Good evening, Dr. Sable.
Good evening, sir. One thing. Is it visible, sir?
Yes, it's visible. You're audible. You can start.
Okay. Good evening to one and all present here. Very good evening to Patwardhan sir, Karganis sir, Shyam sir. I thank the organizing committee for giving me an opportunity and finding me worthy enough to go ahead in this prestigious competition. My name is Dr. Aashiket Sable, and today I'm going to be talking on arthroscopic partial meniscectomies, which might be a bit of a forgotten art. This is a research-backed presentation. A lot of comparative trials, systematic reviews, meta-analysis were studied through PubMed, Google Scholar, or sources were published within the past 10 years, and studies with high citation index were chosen only. Just to give a brief overview of what I'm going to talk about, in this era of saving the meniscus, arthroscopic partial meniscectomies is still the most common surgical procedure performed worldwide, but it is subjected to a lot of criticism given the Save the Meniscus campaign, as well as a lot of trials and all going on, comparing it with conservative management or even sham surgeries. So I just want to put some light on the fact that with accurate patient selection and technique, this procedure, the APM, can work wonders. So these were the RCTs I was talking about. Major RCTs have been done in the recent literature, which have compared APM with physiotherapy alone, with conservative management, as also with sham surgeries, and they've somehow proved how their lines of treatment have given better results than partial meniscectomy. So to begin my talk, the meniscus goes way back, somewhere around 600 BC. Johannes Kepler was the first person who described the meniscus as a crescent-shaped body. Previously, total meniscectomies were done, but because there were a lot of complications, we have shifted to partial, segmental, or circumferential meniscectomies. The function of meniscus, as we all know, is to reduce contact stresses, allow stability, nutrition, and lubrication to the joint. The meniscus is subject to a lot of loading, compressive rotational stresses, and shearing forces, which make it vulnerable to a tear. Structurally, the menisci move with knee motion, and we all know that they have a poor capacity for healing, not only because of the vascularity, but because of the location, complexity, and chronicity of the tear, as also because of the deformation of the meniscus. And if there are any concomitant injuries like an ACL tear or some angular instabilities, angular alignment issues. So the question arises, that is anatomical repair of a pathological tissue and exercise in futility. Aging and degeneration can alter the collagen structure of meniscus, but mind you, aging and degeneration should not be considered similar, because degeneration can even occur in a young patient. The patient factors that influence decision making are the symptoms, disability, age of the patient, limb alignment. Simple indications for a meniscectomy would be a defective, deformed, degenerate meniscus causing mechanical symptoms. And I would also like to state that not every torn meniscus is amenable to repair. The structural factors influencing meniscectomy are the location of the tear, a degree of the tear, the pattern of the tear, as well as the morphology and extent of degeneration of the meniscal tissue. So a decision to resect is not only based on the MRI image, but it is a combination of a lot of factors as given here. The ultimate goals of a meniscectomy are to resect the unstable segment, preserve a stable rim, minimize chondral scuffing, and to avoid chondral damage. Meniscectomies may be difficult in tight knees, knees that go into a pivot, or those with osteophytes. Caution should be exercised in case of extruded menisci, in cases of chondral wear and where there is bone edema. These are the type of meniscectomies which are performed. So the prerequisites for an optimal meniscectomy, I would say, would be the use of proper instrumentation, adequate visualization of the joint, the ease of access, proper portal placement and switching of portals, the position of the leg, and proper initial probing. As regards to any other procedure, the meniscectomy also has some complications and pitfalls, like there may be inadequate probing, which might miss some injuries or tears. Instruments might get broken. There might be loss of some meniscal fragments, extensive chondral injury, damage to collaterals cruciates, or some neurovascular injury. Now the currently trending topic, meniscal repairs. It is trending now, but it has been dated way back to 1980s. The factors that matter are similar to meniscectomies, like the location of the tear, the degree of the tear, the chronicity of the tear. Here are some zone-specific repair techniques which have been published. But the ideal tear for a repair would be a longitudinal tear in the vascular red-red or red-white zone without any secondary tear, and a white-white zone should never be repaired. White-white zone tear should never be repaired. I feel the pros and cons of repair techniques go hand in hand with regards to the availability, affordability, ease of use, failure rate, and cost effectiveness. So meniscal repair is no doubt the treatment of choice for meniscus tears. Concomitant ACL reconstruction improves healing rates of the repaired meniscus, but the failure rate for an isolated meniscal repair is somewhere around 43.5%, as shown in this article from 2021. And arthroscopic partial meniscectomy is ultimately proven to be the treatment of choice for a failed meniscal repair. Nowadays in vogue are the meniscal transplants, which can either be a total transplant or a partial replacement of the meniscus. But this also has some disadvantages as shown here. And the failure rate of a meniscal transplant is reported to be around 31.8%. So just to shed light on the fact that the meniscus treatment has evolved massively over the years, ranging from what began as a total meniscectomy, then shifted to partial meniscectomy, then going into repairs, and then going into meniscal restoration. But I feel partial meniscectomy has still stood the test of time and has given wonderful results over the years, as shown in this article from 2022, which was a review article, which stated that patient selection was key. And the ideal patient for a meniscectomy would be somewhere around 18 to 50 years of age, with knee pain for more than 1 month, with an MRI confirmed meniscal tear, with grade 0 to 2 on the Kellgren-Lawrence osteoarthritis scale. From their study, they have proved that majority of the patients have returned back to sporting activities and their normal activities, and only 4% of patients have got poor prognosis, and they've got good post-operative scores too. So in conclusion, I would like to say that no procedure is good or bad. Every procedure has got its complications and pitfalls, but an arthroscopic partial meniscectomy, if done with proper patient selection and technique, can yield wonderful results. And the amount of criticism going on is something to be debated upon. This is just joint space of a patient 32 years after meniscectomy, living his life happily now. These were my references for my talk. I thank you all for giving me your time and attention. I leave the house open for questions now.
Thank you, Aashiket. You finished in time. So open to questions. Karkani sir.
Okay, so good presentation, Aashiket, but I just want to know MRI. The MRI, on MRI, how do you decide whether the patient requires arthroscopy or not? I'm not talking about those where there is a peripheral detachment red zone, nor am I saying about the vertical tear which you showed was in the red-white. That can be sutured. But how on MRI? Because MRI is very confusing to, they'll say, okay, there's a tear, not going to the cartilage, not going here, not going there, grade 1, grade 2, grade 3. So you have to subject a patient to arthroscopy. And okay, then some patients have mediclaim, so you are doing that, but non-mediclaim patients spending 1 lakh, 1.5 lakh, how do you decide?
Sir, I feel the MRI, sorry, sir.
Pre-operative, how do you decide?
Sir, I feel the MRI is not just the deciding factor for surgery. Obviously, the MRI is an important factor, but I would also look at the patient clinically, as well as take some weight-bearing X-rays of him. And all these three factors combined would help me make a decision about subjecting the patient to a procedure. I would obviously not promise a patient a meniscectomy or a repair, but and I would like to obviously do a diagnostic evaluation of the joint first before going into any procedure. Yeah, so I would have the radiological as well as the clinical aspects in mind, sir, before suggesting anything to the patient.
Okay, forget the MRI because that is very confusing to me, where it is located, this, that. Clinical, how do you say it clinically?
Sir,
the patient needs that arthroscopy for excision, that is partial meniscectomy. Clinical.
Sir, Sir, so that's what, sir. I would not promise the patient anything on clinical or radiological aspect unless and until I visualize the joint from inside, sir. I would make sure that the patient is open for both the options. But once I go into the joint and visualize the tear, I would make my final decision, sir, whether I want to go for a meniscectomy or a repair.
So that is, you are very ambiguous in giving the patient an outcome. And that in practice is not very good, because if you don't give outcomes to the patient will not come back to you, and nor will he send you patients. So forget all that. What I want to say is, in literature, how do you decide patient requires arthroscopy?
Sir, I would stick to my point. In literature also, they have said that it is a multifactorial decision based on clinical evaluation, MRI, as well as the adequacy of the joint space, which we get on weight-bearing X-rays. I would do as backed by literature, a comparative X-rays of both the knees together. In AP view, especially to see if the joint space is adequate.
X-ray, that's it. No, I don't think that is very correct to assess whether the patient requires arthroscopy, because you have to be so specific to a patient that you want to give an outcome. You can't do a spring cleaning. A spring cleaning patient once again comes back with osteoarthritis, and then he'll be cursing that why I have undergone this arthroscopy and spent so much of money. So the criteria to select the patient for arthroscopic partial meniscectomy has to be absolutely perfect. Like we have the some physiotherapy or something, you're given a patient improves, something has to be there, no? That's what I'm trying to tell you.
Yes, sir. But my major decision criteria would be the clinical evaluation, sir, more than anything else. The history of the patient, since when he's got the complaints, if at all there is a traumatic tear or a traumatic degenerative thing. So I feel the clinical evaluation would be my first criteria, and second would be radiological, sir.
You said degenerative. Now, how are you going to stop the degeneration by doing partial meniscectomy?
No, sir. It was just an example. I wouldn't be able to stop the degeneration.
Yeah, so therefore those are totally out. That's what I'm trying to say. For example, in one of the Virox, when I was a examiner for posters, one guy from KEM, he presented a figure of 4. You see, if you can't do a figure of 4, like how Sri Sai Baba sits, that type, you see, and the patient cannot touch the knee to the floor, it is a posterior horn of medial meniscus tear. And very often these patients come with hip pain. This hip is paining, but when you see actually the hip is not paining, that when they do the Sai Baba type of a position, on that side, the knee cannot touch the floor. And we gave him a prize for that. Sunil Shane was the joint examiner for that, on that Viroc, I remember. So have you found anything on that figure of 4 test for posterior horn of medial meniscus? It is there in Google search. Have you seen that?
No, sir. I haven't come across that.
Yeah, that is the indication that patient has got a posterior horn of medial meniscus, and therefore this is that one, and you will get it on MRI also, that the posterior horn of medial meniscus is torn. And these are the patients who might do well because they cannot do the Sai Baba type of thing, and they'll say we are complaining of hip pain, and they have a lot of physiotherapy, 4 or 5 physiotherapists trying for hip, but it's not the hip, it's the knee. So flexion and abduction, that is restricted. That test is in your presentation, right?
Yes, sir. It's not there.
Okay, it doesn't matter. But good, overall good.
Thank you, sir.
Sandeep, sir, any questions?
Yeah, Aashiket, thank you for a confident lecture on meniscus and indications of arthroscopy without talking even once on what is the literature saying about it. Your last slide was one slide on literature. I thought the purpose of this whole exercise was to look at literature critically and try to tell us with evidence how partial meniscectomy is equivalent, if not better, or what are the shortcomings and failures of doing meniscal repairs. Instead, you gave us a lecture which is for postgraduates on which ones to repair, multifactorial, how it is degenerative, how new meniscal transplants are going to come up. See, I think this was not meant to give a lecture, no? This was a literature review session. And we wanted to see whether you can read different papers on your topic, analyze them, and then give us a critical appraisal of why a certain thing is working or is not working, or it is biased or it is not biased.
Yes.
Instead, you are giving a postgraduate lecture on how to do meniscectomy, and you are vacillating between clinical and radiological. On one hand, you are saying I'll put scope in every joint and see. I can't rely on clinical. So overall, I think there is a lot of confusion in what you are trying to do through this presentation, or you have not understood the nature of this whole purpose of the rising star. And I'm see, you are our student, so I can be more critical of you.
Yes, sir, definitely. Sir, so I have obviously gone through a lot of literature, sir. Actually, we are even publishing a study now regarding meniscectomy. But sir,
That doesn't
as
matter.
far as
I
sorry,
did
sir.
not see a single slide which said that so many meniscal repairs have been done, so many have failed, so many have been revised, so many caused problems. The analysis of this was so many were degenerative, so many were young patients, so many were old patients. Meniscectomy, so many had immediate relief. This was the score. This is early return to sport. And they have not suffered long-term degeneration. Nothing. You just kept on talking. 80% of your slides was a lecture on meniscus and meniscectomy. I don't think you got what is required of this symposium.
Sir, as far as I have studied, sir, the literature, there has been a lot of bias on meniscal repairs and everything other than
Yeah, but where
meniscectomy. Yes,
where
sir.
did you present
I
it?
haven't mentioned it.
You
Yes,
have
sir.
read it, doesn't make any difference. The whole
Yes, sir.
presentation was supposed to be show us the literature. Tell us how you analyzed it. Tell us why you are saying that this is a good procedure and meniscal repair is not so good. Where is it?
I know. Yes, sir. I'm sorry, sir. I haven't put that.
Okay. Okay, I think thanks Aashiket and thanks judges. Let's move on to the next candidate.
Thank you, sir.
Thanks. So, Dr. Ashraf, you can share your presentation.
Yes, sir. Is my screen visible, sir?
Yes.
Yes.
Go ahead.
Okay. Good evening, everyone. I am Dr. Ashraf Shaikh, Assistant Professor at Department of Orthopedics at KM Hospital, and I'm going to be talking on spinopelvic mobility and its implications on total hip replacement. So, man has come a long way from being quadruped to a biped animal, and we now know today that no two pelvis are the same. Going back 40 years, where Levinek described the safe zone of acetabular cup placement, which was 40 degrees of inclination and 15 degrees of anteversion, it was considered as the holy grail for the acetabular cup placement till very recently. However, in the last few decades, a lot of studies have come up, especially the one in CORR, where they analyzed around 10,000 hips at the Mayo Clinic. The rate of dislocation was around 2%, and they found that 58% of these hips were actually within the Levinek safe zone, which makes us understand that there is some other factor responsible for this as well. Instability of THR is actually a very major cause of its failure. 1 out of the 5 hips that we are actually revising is because of some kind of instability or dislocation related complications. I've done a thorough review of literature on the electronic databases and included the most relevant articles that I could find. We're going to be discussing spinopelvic movement, some parameters, and the implications these things have on the acetabular cup placement. So the spine, pelvis, and hip move in a very complex interactive way, where when we are from standing to sitting, there is movement of the lumbar spine, the pelvis, as well as the proximal femur. And this has actually paved the way for a functional acetabular positioning as compared to a static one that was described by Levinek over 40 years ago. So normally, when we're shifting from a standing to a sitting position, the hip flexes, then there is a posterior pelvic tilt. So posterior pelvic tilt increases, as we can see on the X-ray. Lumbar lordosis decreases. The sacral slope, which is actually the angle between the sacral upper end of sacral end plate with the horizontal line, that also decreases. And since the hip is flexing, to accommodate the proximal femur, the acetabulum and the pelvis actually opens up, and this is known as biological opening of the acetabulum, which increases the anteversion as well as inclination of the acetabulum. Now, this concept of anteversion along with inclination has been termed as anti-inclination by Larry Dodd, and this is actually based on a lateral X-ray where we draw an angle from the posterior inferior aspect of the acetabulum to the anterior superior aspect with a horizontal line, and this is known as anti-inclination, which actually gives relevance about the mobility of the acetabulum from the standing to the sitting position. It increases in the sitting position. And the second one is the pelvifemoral angle, which is the arc of motion of the femur. And when we add these two, the sum of these two is the combined sagittal index, which is actually the functional safe zone, which should ideally replace the Levenek's safe zone. And this is around 243 degrees in standing, and it reduces to around 175 degrees in the sitting position. So this is actually the impingement-free zone. There's a lot of data on complications after lumbar spinal fusion in total hips, where not only are the dislocation rates higher in these patients, but also they are with more number of levels that are being fused, the dislocation rate is higher. In one of these studies from Journal of Arthroplasty in 2017, the authors have found that 7 times more likely are these patients of lumbar spinal fusion more likely to dislocate than the patients with total hip alone. And that's not our only problem. Also, not all stiff spines are instrumented. The vast majority of these patients with a stiff spine do not actually have an instrumented fusion. Therefore, we need to really evaluate them clinically and examine them. And that is where the question of radiographic evaluation comes up. So a standing AP pelvis X-ray is important. Along with that, a lateral spine pelvis hip X-ray needs to be done. So in an anteriorly tilted pelvis, it would appear like an inlet view on standing. A posteriorly tilted pelvis would appear like an outlet view on a standing AP pelvis X-ray. When you are trying to classify this, we use the difference of sacral slope in standing and sitting. So when it is 10 to 30 degrees, it is considered normal. Less than 10 degrees of difference between the sacral slope on standing and sitting is stiff, and more than 30 degrees is hypermobile. So in the stiff spine comes stuck standing, where the pelvis is anteverted and it is stuck in that position on sitting or standing. Stuck sitting means that that the pelvis is rolled back and it is stuck in that position irrespective of the patient standing or sitting. And the third one is neutral. So coming to stuck standing, there is no pelvic rollback to accommodate the flexed femur on sitting. So there is no increase in acetabular anteversion on sitting which can accommodate this proximal femur. This leads to an anterior impingement and a increased risk of posterior dislocation. Whereas in stuck sitting, the pelvis remains stuck in a rolled back position. So when the patient gets up from a sitting position, there is no decrease in anteversion on standing. This will cause a posterior impingement, and therefore the risk of anterior dislocation on standing increases in these patients. So we now know the problem. What is the solution? So the solution to place these cups is that in a stuck standing position, we need to increase the anteversion by around 5 to 10 degrees to make sure that the anterior impingement reduces and there's lesser risk of posterior dislocation. In the patients who have stuck sitting kind of a spinopelvis, we need to decrease the anteversion by around 15 to 20 degrees to reduce the risk of anterior dislocation when the patient stands up. And the neutral stiff can have a risk on either side. Therefore, maybe a dual mobility articulation can be a good option for these patients. A lot of patients present with hip and spine pathology together. And in these patients, if the patient has a hip flexion contracture, then we must go ahead with a total hip first, because usually when we do a total hip, these hip flexion contractures get corrected and the spinal imbalance also gets corrected. On the other hand, if there is no hip flexion contracture, then we need to address the one which is more symptomatic first and monitor the other and then tackle the other accordingly after counseling the patient. No talk on total hip arthroplasty is complete these days without talking about dual mobility hips, and they have been very promising. A lot of data is coming up from a lot of registries, one of them being the American Joint Replacement Registry, where they've analyzed 15,000 hips, compared it with dual mobility versus non-dual dual mobility for lumbar spinal fusion patients, and they found that dual mobility hips have a statistically significant lesser rate of dislocation in all of these patients. Regarding the use of algorithm for using a dual mobility implant, if there is just a single intermediate risk factor that is present in these patients, then we can go ahead with a conventional implant. However, if there are 2 or more intermediate risk factors for dislocation, then a dual mobility implant is ideal. And whenever there's a higher risk of dislocation, for example, in spinal fusions of 3 or more levels, or there is absolutely no change between the sacral slope in standing and sitting radiographs, then we should again go ahead with a dual mobility implant. So in summary, I would like to say that acetabular version is not actually a static concept. It's a dynamic concept which changes from standing to sitting. We need to identify these patients who are at risk for spinopelvic stiffness and a sagittal spinal imbalance. The X-rays of AP pelvis standing and lateral spine pelvis hip standing and sitting X-rays are very important in these patients. These help us classify these patients according to their mobility criteria. Accordingly, we will then modify the acetabular component, and in high-risk patients, probably dual mobility total hip arthroplasty is a very good option. These are the references that I have used, and I thank Bombay Orthopedic Society and everyone for having me here. Thank you. Thanks a lot.
Thank you, Ashraf, and you finished on time. Questions from Karkhani sir?
So, Ashraf, a very good presentation. I'm sure that it must be from Dr. Mohan Desai's unit, right?
Yes, sir. I work in MMD sir's unit itself.
Yeah, that's what I was thinking, because he is very much versed in this spinopelvic mobility. So now you say that if the spine is stiff, then while the patient is sitting, then there is no anteversion of the hip, right? Of the acetabulum. So it will dislocate posteriorly. No?
Yes, sir. Yes, sir. Yes.
And when does it dislocate anteriorly?
So it dislocates anteriorly when the pelvis is in stuck sitting position. So the pelvis is rolled back. So the anteversion is high. The anteversion is high when the patient is sitting. As soon as the patient sits up, ideally the pelvis is supposed to get anteriorly tilted again. But in this case, it does not. So when it does not, there is anterior overcoverage of the femoral head, and that causes an posterior impingement and an anterior dislocation. So these patients typically will dislocate.
When does that happen?
So this would happen, sir, when the pelvis is in a rolled back position. When the pelvis is in a rolled back position, it's stuck in a stuck sitting position, sir.
Okay. Right. Yeah. So I don't know how many of this thing is known to people who are doing THR all over the country. But review of literature you have done on this, right?
Yes, sir. Yes.
And what does it say?
So it says that it's very clear on these factors that the Levenach safe zone. Actually, there are a lot of papers on this, and it's been going on for the last almost 10 to 15 years. The literature dates back to 10 to 15 years, where they're saying that in fact there's a paper that's called as death of the Levenach safe zone, where they're trying to say that that there's no one size fits all. So the same version and inclination is not same for all patients. That's one. And second is, even in patients we have performed a total hip over years, they will probably develop a spine pathology, and then their spinopelvic mobility will become abnormal, and that may be a cause for this dislocation. So understanding this, yes, sir, yes. So first we need to understand these concepts, and the literature is actually quite clear on this. That in all of the slides that I showed, the literature is very clear on the fact that there is no single safe zone, and all of these zones are dependent on how the patient presents to us in that stiff spine.
So in due course of time, if the patient has got avascular necrosis and he has got osteoarthritis of the hip, and that is in the young age of 40, and you do a THR, and then in old age the spine is going to get stiff. So then does it mean that it will dislocate posteriorly later on?
The patient has a risk of that, sir. That may be a cause of dislocation over time in the patient. That is one of the causes of dislocation over time, and that will become relevant when we go ahead for a revision of that hip replacement, because then we need to get all these X-rays of standing, AP pelvis X-ray, and lateral radiographs standing and sitting, and we need to see whether there is any spinopelvic mobility abnormality or not, and then accordingly place the acetabular components, sir.
That will be abnormal, because at the age of 65 he has spondylosis, so spine will be stiff.
Yes, sir.
So you have any Indian publications on this?
So Indian publication was only, I found one Indian publication, but that was also a review article actually. It wasn't any comparative trial or comparative study that was done. Most of the literature that I could find was either published in the US or the United Kingdom. So.
Yeah, that's right. So what are you doing in your unit? Because Dr. Mohan Desai is quite adept about it, no?
Yes, sir. Yes, sir. So we have actually started getting these X-rays done for patients who are at risk. So if any patient comes to us with a dislocation, then it's a must for us to get a lateral X-ray in standing and sitting position to assess to assess the anti-inclination of that patient, whether there's a change in sacral slope or not, to see if there's a spinal stiffness. And if we do find that there is spinal stiffness in these patients, then we consider giving an antiversion as well, but we also have a low threshold for using the dual mobility articulation actually. So when we know that the patient is old, patient has risk factors, then we go ahead with the dual mobility, and that really seems to be very forgiving.
Yeah, that's true. Very good. Yeah. So very good. I have no more questions for you. Anybody else? I think Sandeep is not around. So Sanjay, are you there? Hello? Ashok? Acha. So Ashraf, can you hear me?
Yes, sir. I can hear you, sir.
I don't know where is Ashok, Shyam and Dr. Sanjay Dhar.
Yes, sir, we can hear.
So Dr. Sanjay Dhar is there?
Sir is not connected right now. He mentioned that he is outside, is in a poor connectivity area.
No, I think what Ashraf has, Dr. Ashraf has presented is a very good thing. And what he's saying that most of the patients with osteoarthritis because of AVN, they are done with the totally replacement. But that factor, we do not know what is going to happen when the spine becomes stiff. And if it is not going to tilt, then it will dislocate anteriorly.
Right.
So very good point. And what he says is if the spine is stiff and if we are doing a THR in his unit, then and if there is loss of mobility, then dual mobility cup is indicated. It's a good presentation. To my mind, I think it's good. I hope that the THR people in India know about this. Yeah.
Thank you, sir.
Okay.
Thank you.
I think,
yeah, good. Very good.
Thanks,
you.
Dr. Ashraf. And
thank you, sir.
I think with that, we come to the end of this Rising Star. We are coming to end of both first round and second round. And we'll be selecting 5 candidates from amongst these in second round who will be presenting in VIROC. We'll announce the result, I think, by Sunday, and we'll let you know. So thanks all of you.
Thank you, sir.
Thank you. Yes,
Thank you,
and thank you all presenters. Shahrukh Khan on HTO, you tell me something about the medial collateral ligament, and Anushrav Rai on cemented stem. They are quite popular in UK, as you say, but not in America. The Americans have their own different method of thinking, I think. And Priyambada, yes, that traction. So I think you should do that. What I was saying, the hanging tree. Or you should take 2 fellows, you ask them to hold the bar and the patient can hang on it, but you don't hold the bar. Tell Arvind. Arvind was a registrar, very popular. Yeah. Okay, give him my hello. And Aashiket Sable Arthroscopic. Yeah, you have to be very careful. So you see what happens, what I wanted to, since you are young, you have to give outcomes. You cannot do a surgery without outcomes. The patient, suppose you got a degenerative tear and you do that, and he's already got some changes in the cartilage. And that you can see on the MRI, thinning of the cartilage. That candidate you should never touch because he'll come back and time is gone and money is wasted. And spino-pelvic mobility, Ashraf, very nice, very good. I hope you send this message all over the country. That is important. Right?
Thank you, sir. Thanks a lot.
Thank you, yeah. And thank you, Ashok Sham, for taking me on this for as a judge. And thank you all presenters, Ashraf, Priyambada, Aashiket, Anushrav, and Shahrukh Khan. Yes.
Thank you. Okay. Thank you, sir.
Thank you very much, sir. And
thank you, and all the best for the winners to present it in VIROC. Let's see what the committee decides upon the marks. Yeah.
Thank you.
Thank you, sir. Thank you.
Thank you, sir.
Okay, bye then. Yeah. Good night.
Bye, sir.
Bye. Good night.
Rishi, you can stop the presentation.